Hello. Good evening. Um, we are. I just happened to check the schedule today, and we're uh, quickly approaching the end. So, essentially, this will be the last lecture I post before finals week. So, um, we have this, which is the lecture for the Thursday class. And then we have next week is, of course, Thanksgiving break, and finals week is the week after. Um, I will make every effort to get that final exam posted as early as I can, since I do have quite some time to work with it. That way you can go ahead and at least wrap this class up whenever you see fit. So um, tonight, the topic of the evening is neurodevelopment disorders. So something that is of keen interest to me. I've mentioned several times throughout the class. I have a son who has autism. He's 10 years old. So this is a section of this class that's very important to me, and one that holds special weight. Also, the first topic of the evening is attention deficit hyperactivity disorder. Also something that's kind of near and dear to me. I don't know how dear it is, but definitely near to me. A disorder that I've struggled with myself. Oddly enough, mostly through adulthood. I wasn't diagnosed until I was an adult, even though the signs were clearly there as a juvenile. I just didn't really know what that was. So, but that is something that also I find keenly interesting. So some of the things that we're going to talk about tonight: ADHD, talk a little bit about learning disorders and intellectual disability. But for the sake of time, I'm not going to spend a whole lot of time on that. Just kind of go over the highlights, and then we'll talk about autism. So areas that are particularly interesting. We probably won't cover delirium or some of the neurocognitive disorders like Alzheimer's disorder or dementia, really for the sake of time. I've since midway through the class, I've started recording these on putting them on YouTube Live, which makes the recording available to you all. And it's much easier for me, but also they limit me in time. So I have to be a little more efficient, which I'm sure breaks your heart. So, in terms of these disorders, keep in mind, this used to be a section that was referred to as, in this textbook in different editions, has been disorders of childhood. And these still very much are disorders that are diagnosed in childhood, even if they are not disorders that strictly affect children. We all know ADHD grows with you into adulthood. Same with intellectual disability and autism as well. So they're like lifespan disorders, but they are just first identified in children. So so that is a little. Let me dismiss this thing that's telling me I need an update. So if I can get rid of that. There we go. Because that's how it goes. You use your computer every day, and then you go to actually do something productive, and it wants to update. Well, I'm looking on the internet or playing fantasy football, it doesn't care. But when I'm actually working, it's time to update. So most of these disorders are first diagnosed in infancy or childhood. ADHD, learning disorders, autism, intellectual disabilities, and other communication disorders almost exclusively are either identified in childhood or diagnosed in childhood. For example, ADHD requires that you have symptoms prior to age 12. Intellectual disability, formerly known as mental retardation, is a disorder that has to, by definition, have developed prior to the age of 18. So a lot of these disorders have that, adolescent childhood onset in their criteria. So we'll start with ADHD tonight. And ADHD is attention deficit hyperactivity disorder. So if you want to know what it is, all of it's in the name. Problems with attention, overactivity, or impulsivity. And this can have behavioral, cognitive, or social and academic problems, usually some combination of all of that. And there are different types. You can have predominantly inattentive. So people who have ADHD, predominantly inattentive type, tend to have a hard time focusing, paying attention. This often looks like it manifests in class. So this is often the first time that people know they're struggling to pay attention. It isn't an intellectual disability. It isn't a learning disability. They're just having a hard time focusing. Predominantly hyperactive and impulsive, meaning they are more likely to act out. Again, think of young children in a classroom. They're more likely to speak out of turn, get up and walk around the classroom. They're not allowed to do something kind of distracting or that breaks the rules just because they're overstimulated and have a hard time. And then a combined presentation, which is really fairly common. Often tell a story. I definitely am. I think this is how it works with ADHD. I'm definitely more inattentive than I am hyperactive. But it would be very rare for a person to only have symptoms of one. I always tell this story that when I was in elementary school, probably second or third grade, my class was, I don't know if it is still that way, but in elementary school, you used to line up and they would take you down the hall to the bathroom. So we were going on a bathroom break. We were lining up, going down the hall in the bathroom break. And the other class next to us was lining up to go to recess, and they were going outside. And so I decided that I was going to just hop in line with them and go outside instead of going to the bathroom because I didn't have to go. It made perfect sense to me at the time. So I went outside and played on the playground and nearly was all the way through with the recess hour or 45 minutes, whatever it was, before my teacher sent somebody out to find me. I think they saw me in the window and somebody told on me. So, but it was like this impulsive act that completely made perfect sense to me and was completely okay. And it wasn't trying to break the rules or trying to, cause trouble. It was just something that it was like this impulse that it never occurred to me that I shouldn't do. So I think that's a good example of what that can look like sometimes. It's not often harmful, and usually in kids, it is that sort of thing. Just this impulsive act and often just talking when you're not supposed to. Also got in trouble one time during some sort of assembly or some kind of event where we're all in the gym, and I was like making funny faces at somebody across the, we were little, so making these funny faces, sticking my tongue out probably at some kid across the gym, and the teacher thought I was doing it at her, and so I got detention for that. But again, just like this impulsive thing that really isn't harmless, but just is kind of distracting. So the DSM criteria for ADHD, persistent pattern of inattention, hyperactivity, impulsivity that interferes with functioning. It's characterized by 1 and or 2. So number 1 being inattention. So 6 or more of these symptoms persisting for at least 6 months. So again, it's ongoing. It's inconsistent with development. So it isn't because of age. Young children often look like they have trouble focusing and paying attention. So this is not developmentally appropriate. This is something that other kids the same age would not have quite the same trouble with. And it negatively impacts social and academic or occupational activities. So these are 6 or more of the following: failure to give close attention to detail, trouble sustaining attention, doesn't listen when spoken to directly, doesn't follow through on instructions or fails to finish coursework, has difficulty organizing tasks and activities, avoids tasks that require sustained mental effort, loses things necessary for tasks or activities, is easily distracted by extraneous stimulus, and is forgetful in daily activities. Now, some of these, all of you sound like some of these. It is every person has some of these at some point in their life. Not every person has all of these or most of these every day of their life. And that is where we differentiate between normal level of functioning and ADHD. So in adults, it looks a little different. The things that you notice, because you learn to cope over the years, and you're not going to get up, you're not as likely to speak out of turn, even though you may want to. You get a lot of fidgeting. You get more things like losing your keys or having a hard time remembering basic tasks, being late with deadlines, or having trouble turning things in on time, just being disorganized and kind of messy. But like anybody who ever has ADHD, like they can be messy, but if you ask them where it is, like it's a different type of organization system. Like I know where it is. You may not know where it is, and it doesn't make sense, but it makes sense to me. But it looks a little different in adults just because you learn to cope over time. Hyperactivity and impulsivity is the number 2. So 6 or more of these for 6 months. Again, not appropriate for your age or development level. So often fidgets, taps hands, or squirms in the seats, maybe a little bit of rocking, often leave seats in situations where you're supposed to remain in your seat. When you're in class, you're supposed to stay in your seat until you're told not to. So these people are likely to get up and have trouble remain seated. They're going to be fidgety. They may play with, pencils or objects, or twirl their thumbs or twirl your hair. Just little things that, little fidgeting things that help with the distraction. Runs or climbs in situations where it's not appropriate. And adolescents or adults, they may be able to control this more, and so they just may explain feeling restless, and that may be the key marker there. Often unable to play or engage in leisurely activities quietly. Being quiet can often be a struggle. Is often on the go or acting as if they're driven by a motor, and talks excessively, blurts out an answer to a question before it's been completed, and has difficulty waiting his or her turn. So all of those things. Several of the inattentive and hyperactive or impulsive symptoms were present prior to the age of 12. So there has to be some indication, even if it was diagnosed as an adult, that this has been going on since age 12, before the age of 12. It used to be 7, so we expanded that a little bit just to be more inclusive, because it is very hard. I'll tell you, as an adult trying to get a diagnosis, and I didn't want to, there were people trying to do that for me, but trying to get a diagnosis, you have to have proof that it exists prior to 12. So trying to find, or 7 at the time. So trying to find teachers or people who knew me back then was pretty difficult, if not impossible. Clear evidence that symptoms interfere with or reduce the quality of social, academic, and occupational functioning. Primarily, you'd have issues here in the first 2, the social and academic world, but also some like on the job functioning, but obviously that's more for adults. But the social and academic part is something that a lot of adolescents struggle with. Are you okay over here? Do you want to interrupt to show us that you also have ADHD? Yep, he does. And the symptoms aren't explainable by other things, schizophrenia or bipolar disorder, what have you. This is about 5% of school-age children. There was this big debate for years about whether ADHD was overdiagnosed. Probably misdiagnosed, but maybe not overdiagnosed. We all know people who probably should be diagnosed who never go get testing, and people who probably don't look like they have ADHD who have tested. So it's just hard to say. but 5% seems about an accurate number, maybe a low number. Symptoms are usually present pretty early on. We talk about needing symptoms by the age of 12, but usually you can start seeing this at 3 or 4 years old. And they are there. I'll try to post a video if I remember to of some school, like 7 or 8-year-old children or even younger, who you can really see the difference, because we say, well, how will you tell in a 3 or 4-year-old? But you really can. There are noticeable differences in how they respond. Boys outnumber girls about 3 to 1 here. So this is unlike a lot of the other disorders where you have more boys who are diagnosed. And this is something that's primarily diagnosed in the United States and at least Western countries. But it does appear, it's diagnosed more often, but it does appear in other cultures as well. There does seem to be a genetic contribution to ADHD. It does seem to run in families. There's also indications that dopamine is indicated in some of these cases. And this dopamine transporter gene, DAT1, has been implicated through some of the genetic studies and, Human Genome Project, that sort of thing. So there is a genetic link and contribution to this. Also, there's some neurobiological evidence that suggests people with ADHD have smaller brain volumes and also have areas of inactivity in the frontal cortex and the basal ganglia, which are the part that control planning and executive functioning, being able to carry out, tasks in an orderly, efficient fashion. So there's abnormal frontal lobe development and abnormal functioning in the frontal lobe, which if you stop and think about what ADHD looks like, that's not terribly surprising. So some of the causes, other than those types of things, some of the environmental causes, a lot of theorizing similar to what we'll talk about with autism, that some of this comes from the role of our environment in terms of pollution or food additives, dyes, and pesticides that have been more prevalent in the latter part of the 20th century on into the 21st century that weren't really present before. Think of like antibiotics in chicken and, the chemicals in plastics like BPA and that sort of thing. I won't go too far in the weeds on that sort of thing, but there is some evidence to suggest that those types of things are linked. Also, just stop to think about your environment that you're in now and some of the things that we didn't have before. I have in front of me, I have a laptop, I have a cell phone, and I have an iPad, all that I'm currently using in one way or the other. Think of the role that probably plays in attention problems. First of all, like, I can be focused on multiple things at any given time. I can watch TV. If I don't like something, I can skip ahead. I can watch something else. It's a far cry from the days when you had like 3 things to watch. And so you're sort of pressured to watch them or just kind of move on and do something else. Everything's a little bit easier in terms of how available things are. If I want to know something, I can look it up pretty quickly. But the role of technology in the formation of ADHD also seems pretty obvious. Also, in terms of biological causes, maternal smoking can increase the risk. Also, infection in utero, which again is the same with every disorder that we'll talk about today. With ADHD, there is some psychosocial things too. Kids with ADHD are often viewed more negatively than their peers. They get more negative feedback from peers or adults. They are seen as people who cause trouble, seen as people who pay attention or bad students or not very smart. So they can be rejected, and also there can be the social isolation and poor self-esteem. Now, I will say that there is some indication that the more intelligent you are, the easier it is to overcome some of the negative feedback from teachers. You're just seen as, if you're smart enough to kind of get by, you can and not really struggle academically. You can eliminate some of that. In terms of treatment, really, your go-to treatments are stimulant medications. Things like Adderall and Ritalin, and Vyvanse and Focalin and what's the other one? Dexedrine, some of these stimulant medications that help kids with ADHD focus. The goal of these is to reduce impulsivity and hyperactivity to improve attention. There are about 4 million kids in the United States being prescribed these types of medications, and they can help focus and attention. They also may increase the risk for substance abuse later in life, so they are tricky. They are addictive. In fact, people who do not need them for being able to focus and pay attention can still get that benefit. They get the stimulant, the hyperactive, the high that comes along with stimulants. They get the stimulation, which isn't as prominent with for people who have ADHD, because they need that level of stimulation to function on a normal level. But if you're already functioning on a normal level, that stimulant medication kind of gives you this high that isn't there with people who are taking it for those reasons. It is the most highly abused drug on college campuses, aside from alcohol. We're excluding alcohol here in this conversation, but it is the most highly abused drug on college campuses. And so it is something that a lot of people use for short-term staying awake or focusing come finals time. And it is effective with that, but it also has a high potential for abuse. And the withdrawals are terrible. I'll say that depends on the drug. The withdrawals from something like Ritalin or Adderall are not that bad. When you get into the more extended release drugs, they can have more serious withdrawals and can kind of be more difficult. Some of the other medications that are used are imipramine and clonidine, which are like hypertensive medications that can help reducing your blood pressure, improving your focus that way. They're sort of, if you remember when we talked about social anxiety and like performance anxiety, using some of those medications for that purpose to kind of increase the focus temporarily. Same premise here. It's a temporary drug. There is also some evidence that genetic testing can help you determine what drugs will work for you the best. So trial and error with medications in this realm is important. Not all stimulants work for the same people in the same way. I took Adderall for years, had pretty decent success with it, although it was short term. Like I had a really high dose of even the extended release. I had to take it 3 times a day and still take a regular Adderall, like the fast acting Adderall, on top of it. And then I switched to Vyvanse, and it worked really well, but it increased my blood pressure such that I couldn't continue to take it. So now I just don't take anything, which is fine. I didn't take it all throughout my childhood, and that was okay too. So we just kind of learned to deal with it. I do think there was some advantage to it, but also it's not worth the health implication that it had on me particularly. So some of the effects of medication, it can improve compliance, particularly in kids who have a hard time with impulsivity. And it can decrease some of those negative behaviors to get them in trouble in school. Doesn't really affect learning, doesn't make you learn any better. It just kind of improves your focus and it doesn't make you more intelligent. It just improves your focus. It lets you live up to your intelligence, I guess. The benefits don't really last past taking it. So when you stop taking the medication, you lose the benefits. Let's see. All right. So also there's some other treatments that aren't terribly effective, like behavioral treatments for ADHD, like reinforcing positive behaviors. These are primarily used in schools with mixed effectiveness, but they also involve a lot of parent training. And I think that tends to be pretty effective. Usually you see a combination of the two, and that's actually more commonly recommended when you use both, like the reinforcement with medication. So let's keep that in mind. Similar to what we see with depression, you often see sort of the mixed approach of using, behavioral reinforcement with medications. I don't really want to talk a great deal about learning disorders. I just want to kind of mention them because it affects what we're talking about with some of the other things. Like it will affect intellectual disability, also a little bit of autism. You do see some people with ADHD who also have learning disabilities. So learning disabilities are essentially academic problems in one particular area, usually reading, math, and or writing. Sometimes you can have learning disabilities in all of those. And your performance is lower than expected based on your age and your capacity. So your performance isn't poor because your intellectual disability. It isn't poor because you don't have a high enough IQ. In fact, that's one of the ways we test for it. If you get an average IQ or an above average IQ, and your math scores or reading scores are substantially lower than that, then it indicates a problem not with your IQ or your learning abilities. It's a problem in that particular area, particularly if you don't have problems in all the areas, like you don't have problems in math or you don't have problems in science. So it's just limited to a particular area or two. And it is long term. So this goes on for 6 months or longer. Let's see. And let's see. So you can have the impairment in reading, which primarily affects word reading fluency or word reading accuracy. So you see a word, but you don't read it correctly. Reading rate or fluency, how quickly you read, or your ability to comprehend what you're reading. That's a common problem with people with ADHD that isn't necessarily learning disorder related, but is focus, attention related. So you read things, but you're not really paying attention. So that is an indication of trouble focusing. So sometimes it is not as easy to figure out as you would like. Also, impairment in written expression. This is spelling problems, grammar and punctuation problems, and just the inability to kind of clearly express thought. And then we have the math disabilities, or learning disabilities, which has trouble with basic arithmetic, inaccurate calculations, or just poor math reasoning. So let's skip over some of that. What do we need to talk about there? So these, like I said, 6 months or longer, and they cause impairment, and they are not what you would expect based on age or intelligence level. So that's one of the important parts here. So you would not expect a 7-year-old to be able to read books that a high school kid would be able to read. So that is something you definitely have to take into consideration. All right. Learning disabilities begin during school age years, but may not fully manifest until the demands for academics increase. So you may have always had these problems, but at some point they become more apparent because things have become more challenging for you. So it is not unusual for people not to identify learning disabilities until like middle or high school when things get more challenging. Sometimes kids are really good at faking it. So they know they can't do something, but are able to convince you that they can, or that their skills are better than you would predict. Also, sometimes kids who have learning disabilities act out in order to get out of the situations that they're having trouble in. So sometimes you think these are just, kids that are behaving poorly, but in reality, they're having trouble learning and don't really know how to cope with that, or are too embarrassed to ask for help. So there is a lot of investigation that has to come in here. So 6 million kids in the United States have been diagnosed with a learning disability. It's probably higher. The highest rate of diagnosis is in the wealthier regions, but children with low socioeconomic status are more likely to have problems. So the kids that are in better schools and wealthier schools are more likely to have the problems identified and have somebody work with them. Kids in low economic places, poorer schools, are less likely to get identified and more likely to have substantial amounts of trouble with it. So there really is something to the better the school system, the better it is that you're going to be able to cope with the learning disability. Reading difficulties are the most common and affect about anywhere between 4 and 10% of the population. And the experiences at school tend to be negative when you're dealing with this. There is a breakdown, like a map that looks at distribution of learning disability. And you can kind of see there is no common percentage. Like Kentucky is 3.46% of the population that has learning disability. Drop down to Tennessee, and that's 6.3%. Go over to Texas, and that's a little over 6%. California is 5.5%, so it's all over the place. But then you go up to places like, I'm challenged geographically. It looks like, we'll just say New England. There's some 9%, is that Delaware? 8% like Rhode Island. So really high percentages, and those are more affluent areas. So you can kind of see a little bit of the breakdown in how socioeconomic factors play a role, but it really just shows that it's all over the place. Learning disorders do tend to run in families, but there are also other factors that play a role here. Usually what we're doing is trying to build up skills in terms of treatment, trying to build up skills. I can't give you a medication. I can just build up the skill that you're lacking. So if you're having problems with reading, I can just work on that particular skill and find ways to compensate and a more targeted approach to how you are learning. All right, questions? Oh, I'm being silly. That's really one of the parts I miss about seeing you all in person is the interaction and getting to actually talk to you. So if you have any questions, just feel free to shoot them to me. Like 0 of you are watching this online because I don't really do it like that. I should probably post it live and then we could have a more interactive way of dealing with it, but it's too late for that now. So autism. Autism is a problem in multiple areas, more than your book list, to be honest. Deficits in language, socialization, and cognitive skills. But also some medical stuff that tends to go along with that too. And I'll try to remember to talk about that at the end. It's very pervasive, and problems span many areas of the life. And there is this huge range of what people with autism are capable of. Think all the way from, one of the things that we tend to think of is people like, I don't know, maybe this is out of date, but things like Rain Man, where you have these people that are like savants and able to just like, they're great with numbers and calculations and skills. And I follow this kid on Facebook who can like see something one time and draw like detailed drawings of it. He flew over New York City and was able to draw like a skyline from memory. Think of these like savant skills. And so we go all the way from people with that, but that just have some like social challenges and some sensation issues, all the way to people who are completely nonverbal, who have academic difficulties, who have intellectual impairments. who have trouble in school, who aren't good at math, or some great, musicians or things like that. So you run the gamut. And we'll talk a little bit about that as we go through. About 25% of this group does not acquire effective speech or nonverbal. My son is nonverbal. He is 10, communicates very well through nonverbal. He can show you what he needs. He can communicate in other ways, but he just can't speak. Also, you have, and this, I will say this used to be 50%. There also used to be, like the last time this book was put out, it was, I think, 50%. So this is a number that is decreasing with the improvements in early identification and speech therapy and occupational physical therapy early on in lifetime. Like this is diagnosed earlier now. You start in like these therapies early on and continue, and they're more intensive, and it does have positive outcomes. The other area of impairment, restrictive, repetitive patterns of behavior, interest, and activity need to maintain sameness, orderliness. Activities need to be the same. Experiences need to be the same. A lot of routine issues. I worked with a kid when I was in graduate school who, like, the only way you could get him to communicate with you was if you did it somehow through dinosaurs. Every story had to be about dinosaurs. Every activity you had that you wanted him to participate in had to be about dinosaurs. He was wholly focused on dinosaurs. My child, for many years, we watched Mickey Mouse Clubhouse. I know every episode by heart. I can tell you the words to every single one. We watched it pretty much all day, every day. He was completely obsessed with it. It's kind of moved on now. He's gotten a little older and is into some other things, but still enjoys Mickey Mouse Clubhouse. So also these repetitive movements. One of the common things that you see is like hand flapping, or hand wringing, or like some like hitting yourself in the head or rocking. All our repetitive behaviors are pretty common amongst kids and even adults with autism. The autism spectrum disorder is sort of new to DSM-5. The autism disorders were identified in DSM-4, but we had other classifications too. DSM-4 had autistic disorder, Asperger's disorder, which is sort of a higher functioning autism, people who are generally verbal and also higher intelligence, but just have social skill deficits, childhood disintegrative disorder. These are kids who have this normal development up until around the age 3, and then they start to lose skills. And then Rett syndrome, which is another form of autism, primarily in girls. So now we've just grouped all of those things into autism spectrum disorder because they all indicate a different level of severity of autism. So the DSM criteria, persistent deficits in social communication and social interaction across different contexts manifest by or history of deficits in social or emotional reciprocity, ranging from abnormal social approach and failure of normal back and forth conversation, to reduce sharing of interest, emotions, and affect, to failure to initiate or respond to social interaction. That's a lot of words. What that really means is trouble interacting with other kids or other peers on the same level. Basic communication, talking. We have a conversation. I talk, you talk. I talk, you talk. With kids with autism, they have trouble with that. If they are verbal, they will want to talk, but aren't very good listeners. May not wait for you to finish before they start again. So they have difficulty with the structure of a conversation. They may not want to or be able to share interests. Like I tell you what I like, and then you tell me what you like. They have trouble with that. Not a lot of back and forth in conversation. Also, emotions are a struggle, trouble identifying emotions in other people, and also trouble in identifying emotions with themselves. And often just are avoidant of social activity. Again, I'll use my son as an example because he's, He's pretty awesome, but he is also a good case study. Um, he loves people. He's very social, but he will rarely initiate that interaction. He's like, he will happily engage with other kids, but like they have to do it first. Like he'll never start um, the relationship. Just terribly shy and has a hard time with that, but is very outgoing. Like he doesn't have the same issue with adults at all. He will engage with adults, but with like same age peers, it's more difficult. Number two, deficits in nonverbal communication or nonverbal communicative behaviors used for social integration, ranging, for example, from poorly integrated verbal and nonverbal communication to trouble with eye contact or body language, or deficits in understanding or use of gestures, total lack of facial expressions and nonverbal communication. So again, that's a lot of words. Trouble with eye contact and body language, trouble looking at me when I'm talking to you, or even responding if you're talking to me to acknowledge that you hear me. And also trouble with the facial expressions, again, expressing emotion. And then number three, deficits in developing, maintaining, and understanding relationships. Trouble maintaining social relationships. Trouble adjusting to various social contexts. Trouble with imaginative play or in making friends. So trouble with imaginative play. They tend to be very concrete. In trouble with pretend play. Pretending, you have a tea party with your daughter or your son. You pretend to drink tea. You pretend to pour tea. A kid with autism would have trouble finding anything meaningful in that or seeing the point. So tend to be just really concrete. Part B to this is the restrictive and repetitive patterns of behavior or interest, followed by two or more of the following. Stereotyped or repetitive motor movements, again, hand flapping or some sort of sensory stimulation, rocking, a lot of fidgeting, insistence on sameness or inflexible adherence to routine, very ritualized patterns of behavior, both verbally and non-verbally, highly restricted or fixated interests. They're only interested in dinosaurs, or only interested in Mickey Mouse Clubhouse, or only interested in Jurassic Park, or what have you. Hyper focused on sensory input or unusual interest in sensory aspects. So they are either hyperactive or hypo reactive to sensory input, and sometimes both at different times. So good example is my son loves motion, like loves riding in cars, swinging, doing anything that involves movement. Usually likes like hugs or like touch, but sometimes not. Like if he's overstimulated, like if there's too much going on or things are too loud, like you can barely touch him, and he's very reactive to that. Like it's almost painful. So this unique sensitivity to sounds or to touch or to all of the senses. There are places that he doesn't go because he doesn't like the smell, and it took a long time to figure out that that's what it was. But so very sensitive to sensory input, either too much or too little. But some kids are more sensation seeking, other more sensation avoidant. Some kids never like to be touched or hugged. These symptoms have to be present in early development period, but may not fully manifest, like we mentioned with ADHD or in learning disabilities, until things become more difficult later on. And these symptoms cause clinical, significant social, occupational, or other areas of your life. They're impairing in school or ability to hold a job or what have you. And they're not better explained by other things like intellectual disability or other sorts of delays or schizophrenia or anything. So when I first took like a child psychology class, like this was like just a tiny bit of what we talked about. We mostly talked about intellectual disabilities or learning disabilities or what have you. By the time I was in graduate school, it was like a huge thing that we talked about. My professor who um, talked about it was like, kind of an expert in autism, and it was a huge focus. And that was like a stretch of, probably 2 or 3 years. Autism sort of exploded. We went from having 1 in 1,000 or 1,200 to having, 1 in like 150. Not even a few years ago when I taught this, it was 1 in 88. Now we talk about 1 in 50 children meet the criteria for autism. That's a lot. Think about your normal classroom being 25 to 30 people. That means 1 kid in every 2 classrooms at least has autism. And so the numbers have steadily increased to the point that the prevalence went from 1 in 1,000 essentially to 1 in 50 in the span of less than 10 years. So it's very shocking to see. And if you don't know someone who has autism, you probably will. It's just so common. More commonly diagnosed in males, but females do have autism. And the IQ interaction I mentioned before when I used to teach this, like the last version of the textbook that we had now said 50%. It used to be more than that had intellectual disabilities. The current textbook says around 38% have intellectual disabilities. The problem is these kids are inherently hard to test. My child is currently going through testing through the school system, and it is very difficult to test children who are nonverbal and who have deficits in so many areas. Deficits in motor skills and deficits in ability to focus and pay attention. And so it's very challenging to test some of these kids for IQ. Some of the causes, historically, we looked at things like just bad parenting. You're seen as just being a bad parent, being perfectionistic, cold, and aloof. I will tell you, I'm not perfectionistic. Higher socioeconomic status tend to play a role here, and also like parents with higher IQs. So this was sort of historically seen as like a wealthier person's disorder. The reality is that because kids who were poor weren't getting tested and weren't getting identified, they were just kind of getting left behind. Also, some kind of the behavioral things that come along with it, self-injury, head banging or hitting yourself or scratching yourself, doing things to stimulate. Also, a term called echolalia. Often this is mistaken for actual speech when it is not. It is just repeating what you have heard. So they may repeat words or lines they see on TV, and it's not indication of actual language. It's just repetition. They may not even understand what that means. Not always. They may understand what that means, or it may be like a way of communicating. There is a movie, and I can't think of the name of it right now, but I'm going to share it with you all. That is really good. And in that movie, what is it? The kid, he had some echolalia, repeated lines out of Disney movies, but his parents noticed that he was using them in a meaningful way. He was actually communicating using lines that he learned from Disney movies, and he was able to go on and develop speech. And I'm going to share that as soon as I can remember it, because I'm just having a moment here. In terms of like biological causes, there is it runs in families. There's a hereditary component. If you have one child with autism, there's a greater likelihood, about 20% chance of having another child with autism, which is 100 times greater than the percentage in general population amongst two just random people. So there is a strong genetic link there, but it isn't 100%. There are numerous genes on several different chromosomes that are involved in autism through the Human Genome Project. So we have several different genetic combinations that may be useful in the future in terms of figuring out who is at risk and helping with treatment. There may be some roles of the oxytocin, the chemical in your body that has something to do with bonding and also with social memory. There may be some deficits in that particular area. Also, older parents are higher risk, so that also plays a role. Some of the brain differences: the amygdala is larger at birth, and that's the part of your brain that has something to do with fear and anxiety. Higher cortisol or stress hormones are very common amongst people with autism. And also there's some neuron damage in the amygdala that comes from high levels of stress, which may cause a problem processing social situations. So all of these things sort of play a role. And their oxytocin, their bonding chemicals are lower. So that may explain some of the social deficits. Here's the thing that does not cause. There's no evidence that causes autism: vaccines. There was a research study published in the Lancet many years ago. I can't remember offhand now. I'm having a moment tonight. But Jerome Wakefield published a study in the Lancet saying that there was a link between the measles, mumps, and rubella vaccine and autism. That was later retracted. There was significant historical information, biographical information on the patients that was just completely fabricated. So that was retracted. That study was found to be not reliable. It has never been replicated. There is no evidence in any research anywhere that suggests that vaccines cause autism. They're linked in time because most people start to see the first signs of autism around the time you're starting to see kids getting vaccines. So they happen to have that link in common. But there are no studies that are empirically validated, that are replicated, that are reliable, that show that. Does that mean that is absolutely 100% not even possible? No, it just means there's no scientific evidence that suggests that it is possible. It's just as likely that, I don't know, venom from a snake could cause autism as there's zero research to suggest either one. So there's higher health risk in not vaccinating. I probably shouldn't say that, but your textbook does. So I'm just reading. I'm not sharing my personal opinion. So some of the treatments that we use primarily are psychosocial, skill building social skills, social skill training, trying to reduce problem behavior and increase positive behavior. So also doing communication skills training, working with kids on ways to communicate if they're nonverbal, working on other ways to communicate, learning how to communicate through writing or through picture exchange boards. I have pictures of things. I have pictures of food. I have pictures of a toilet. I have pictures of a bed. And you teach a child to bring you the picture of the thing that they want. It's like they exchange that in order for that. They bring me, if I were using that with my child, if he brought me a picture of a bed, that would indicate that he wanted to go to bed. If he brought me a picture of food, that would indicate that he was hungry. So you can build communication skills that way. Also, there are a lot of like apps for iPads and things like that. Kids can't communicate verbally, but maybe they can learn how to type or point to a picture who would then read out what they want. So there are ways that you can build communication skills that don't involve talking. But also even kids that are verbal, sometimes you need to work on language production and using language correctly, because there still may be some problems going on there. Mentioned social skills. Socialization is a huge thing with kids with autism. Kids that are more successful in life tend to be more social. So you want to increase the social skills and help them learn how to make friends and interact with other people, interact with adults and children and peers and people in schools and different settings. And you want to do this in their environment. You want to do it in school where they are. You want to do it in places where they can actually use it instead of having everything in like a therapy room. That's not terribly effective for a lot of kids because they may have trouble generalizing some of the skills that they learn. Early intervention is critical. It can help. Your brain is still developing, so you want to get in there and start some of these changes while they're more amenable to it. Biological interventions largely depend on some of the other things that go along with it. Medical intervention really has there's not a lot of medication to improve your social skills or your hand flapping or any of the things that come along there. You can give some medications to reduce anxiety or agitation, things like antidepressants or Abilify or Geodon, I think, are two antipsychotic medications that have been approved for use in kids with autism. You can use medications to help sleep because sleep deficits. I mentioned some of the other things that go along with autism that aren't necessarily mentioned in the DSM as being symptoms, but they are sort of related conditions. So you get a lot of sleep disturbance. Sleep disturbances are very common. So medications that help with sleep, melatonin, or even other sleep medications like Ambien or what have you. Although I don't know that Ambien is very commonly used for this in younger kids. Some of the tranquilizers or things like trazodone or what have you. Also, a lot of like digestive problems. There's some research that suggests that autism is as much a disorder of the digestive system as it is anything else. I think there seems to be a significant amount of kids with autism who have issues in digestion and things like constipation or diarrhea or just trouble with food, being very selective in the foods that they eat. That could also be because of sensory issues or taste issues or any number of problems, but probably everything contributes. So you have a limited food selection because you have some sensory issues because you don't like the taste or smell of certain things, and that causes problems with your digestive system, and that causes you to have pain, and that causes you to avoid certain things, and so it's all intertwined together. Indicators of good prognosis for autism: the higher IQ, the better, and also the better language ability. Also, socialization is certainly something that you want. The better social skills, the more positive. Some of the integrated treatments that are used: multidimensional, comprehensive. Kids are offered special education at school, focusing on communication. Families support it, so you do the same thing at home that you do in school. Often some of the education, this physical therapy, speech therapy, occupational therapy, those sorts of things, working on in different areas. So therapists will come to your home instead of you going to a therapy room, and you know, when you leave, the family still works on the skill building. And when you're older, kind of focusing on reintegration or integrating into the community, finding a way that you can live more independently or as independently as possible. This is sort of a new territory. We don't know a lot about. We know more about kids with autism. We know less about adults with autism and how to handle some of the challenges that they face. But we're seeing more and more kids who have autism who are becoming adults with autism, and so it's something that we're having to deal with. How do we look at finding employment? The encouraging thing is you're seeing more and more employees, particularly in the tech industries, who are focusing on hiring kids or adults with autism to work because they tend to be often are very gifted in certain areas, and like tech, computer industries are often some of those areas where social skills aren't that important. The important thing is the actual work, and so there are some areas that are more likely to hire people who have autism. So shift focus a little bit, talk about intellectual disability. Again, I won't talk about this a ton. But just to mention, intellectual disability used to be known as mental retardation. We've had a change in terminology because it's, well, quite frankly, less offensive and more descriptive. So what we're talking about here is people who have below average intelligence. So if on the standardized IQ test, 100 would be your average intelligence. And so we're dealing here with people who are 2 standard deviations away from average. So have a 70 IQ or below and have trouble with adaptive functioning. They are not able to function or do the things that people who are the same age as them can do. So adults who have trouble tying their shoes or dressing themselves or bathing themselves might have adaptive functioning problems in addition to the lower IQ. And in order to have an intellectual disability, you have to have both of those things. These are first evident in childhood. They must be diagnosed diagnosable, even if they're not diagnosed before the age of 18. If you don't happen to go try to get a diagnosis, but all these symptoms were present before that, then it's still okay. And there's a huge range of variability in terms of severity. The IQ of 70 below, or your textbook talks about 70 to 75. 5 is roughly the standard error of measurement. And so 70 to 75 is a low IQ and sort of mild intellectual disability. Look forward here. So some of the criteria, deficits in intellectual functioning, reasoning, problem solving, planning, abstract thinking, problems with judgment, academic learning, or learning from experience, confirmed by both clinical assessment and standardized testing. Deficits in the adaptive functioning, performing activities of daily life, such as communication, social participation, or independent living, bathing, grooming, eating, that sort of thing. This affects about 2% of the population, so relatively uncommon. 9 out of 10 people have a mild impairment, so are 50 or above. And you get moderate impairment to severe impairment, the more likely you are to have to live in sort of a more supportive environment. People with mild intellectual impairments are often able with support to do some work or have some more independent living skills, and so are able to live more independently with support. People who have severe disability or moderate disability are more likely to have to live with someone or have someone who is caretaking. I mean, it's part of the diagnosis that, so not more likely, they are going to have someone who assists in a more meaningful way. These are chronic. They don't tend to get better. You can't medicate them away. You can't really teach you can teach more skills to people with mild levels, but not with severe, or in even less of moderate. So there's a lot of known causes for intellectual disability. Some environmental stuff like abuse and neglect can lead to that. Also prenatal causes, infections in utero, maternal age, so older moms are more likely, smoking, drinking, doing that sort of thing prenatally. Problems with delivery can also play a role there. Lack of oxygen or having birth complications can play a role. And then other things that happen after you're born, fetal alcohol syndrome, exposure to alcohol prenatally, malnutrition, head injuries, childhood abuse, all things that can contribute to the likelihood of having an intellectual disability. Also, some genetic things like Down syndrome. Down syndrome is almost exclusively attached to some level of intellectual impairment. Let's see. Let's go over some of these things. Down syndrome is the most common chromosomal cause of intellectual disability. It's an extra 21st chromosome, trisomy 21. And they have some distinctive physical characteristics. But again, with the proper level of support, are able to live pretty normal lives, and able to do a lot of things. We're way past the time when we thought people who had Down syndrome or autism had to live in homes and had to be fully taken care of their entire lives. We know that with the proper level of early intervention, support, and care, these kids can do really great things. I just this week saw a story of a young man with Down syndrome. I think he was in his 20s, who completed the Ironman triathlon. My God, that is crazy. Like, I can't even imagine competing that. Like, I certainly couldn't do it. Not on my best day, not like cumulative of over 100 years could I do that. But I mean, it's astounding what people can do. With Down syndrome, higher risk with advanced maternal age. It is detectable in some prenatal tests, amniocentesis, the CVS, and the tests don't really indicate the severity, but just the presence. Also, some of the other causes, chromosomal causes of intellectual disability, Fragile X, which is a disorder that causes like learning disability, hyperactivity, gaze avoidance, poor attention span, things like that. And it primarily affects males. Women with Fragile X tend to have more mild symptoms. It is a problem on the X chromosome. So if you only have one X chromosome, your likelihood of having serious symptoms are going to be more severe, so it impacts males more severely. Women who have two X chromosomes are less likely to. That one is not as important. Not that it's not significant, but you have more protective factors there. Also, some of the cultural causes of intellectual disability, abuse and neglect, and social deprivation, not having access to educational materials, not being able to learn, can certainly cause that. And the treatment is similar to what we talked about with autism, learning basic social skills and practicing tasks, teaching social skills, teaching basic hygiene, how to take care of yourself skills, how life skills, how to pay bills, how to do things like that, how to participate in the community, just more focused, targeted education, things like sheltered workshops, teaching job skills on the job, all are very effective. Okay. I think that is all I want to talk about there. So we have reached the end. You want to say hi, Ty? I'm going to say bye. I'm going to say bye. Thank you all very much. This has certainly been the weirdest semester of my teaching career, which is like 15 years now. But I hope you enjoyed this, and I hope you got something out of it. It certainly changed my approach to class in many ways. But thank you for sticking in there. And if you have any questions or if there's anything I can do, please let me know. I will post the exam coming up soon. I think I did post some extra credit. If you can't see that or can't access that, let me know. And I'm sure I will also put some videos up that I think may be useful tonight. But good luck to you, and I hope you enjoyed the class. And if there's anything I can do or you have any questions, please let me know. Thanks. Good night.